Schools, childcare centers, and healthcare facilities receive particular attention during tracing efforts. These environments involve close contact and can facilitate rapid spread if immunity levels are uneven. When a confirmed case is linked to such a setting, institutions may be advised to review vaccination records or temporarily restrict attendance for individuals who are not adequately protected. These steps follow existing protocols for managing vaccine-preventable diseases. Health agencies have also advised medical providers to maintain heightened vigilance and infection control measures when assessing patients with fever and rash symptoms. Early identification reduces the time between infection and isolation, which is critical for limiting onward transmission. Together, isolation and contact tracing form the operational core of the current response. They explain how authorities translate policy decisions into day-to-day action and why the measures are designed to be targeted rather than disruptive. This practical framework also raises a broader question. If vaccination coverage is high, why do cases still occur at all? That issue comes into clearer focus when looking at the underlying factors behind the recent rise in infections. Singapore's childhood immunization program has achieved consistently high coverage, and measles was previously declared eliminated at the national level. However, elimination does not mean that the risk has disappeared entirely. Health authorities have explained that imported cases and small gaps in immunity can still allow limited transmission to occur, particularly in highly connected urban settings. Several of the recent measles cases involved individuals who were not fully vaccinated or whose vaccination histories were incomplete. In some adults, immunity may also be lower if only a single vaccine dose was received under earlier immunization schedules. While 2 doses of a measles-containing vaccine provide strong and long-lasting protection for most people, no vaccine offers complete immunity. International travel remains a significant factor. Measles continues to circulate in many parts of the world, and cases can be introduced through travel even when local vaccination rates are high. Singapore's role as a regional and global transport hub increases the likelihood of such introductions. Authorities have indicated that some recent infections were linked to travel, while others could not be traced to a specific source. Of particular concern are instances where genetically linked cases appear without known contact between individuals. This suggests exposure may have occurred in public or semi-public settings, where interactions are brief and difficult to recall. Such patterns complicate containment efforts, as contacts may not immediately recognize that they have been exposed. Health officials have also pointed to delayed vaccination as an ongoing vulnerability. Missed appointments or postponed doses can create temporary pockets of susceptibility, especially among young children. In environments where people live, study, and work in close proximity, these pockets can have disproportionate effects. Taken together, these factors explain why measles requires continued vigilance, even in countries with strong public health systems. The recent rise in cases does not indicate a failure of vaccination policy, but rather highlights the need for early detection and targeted intervention. This context helps clarify why authorities opted for mandatory isolation and enhanced tracing rather than broader restrictions as part of a calibrated response to a changing risk landscape. The introduction of mandatory isolation and strengthened contact tracing marks a calibrated escalation, not a shift toward broad population-wide controls. Health authorities have emphasized that these measures are designed to act early and precisely, focusing on confirmed cases and close contacts rather than imposing restrictions on the general public. This approach reflects Singapore's established method of infectious disease control, targeted, proportionate, and evidence-based. For residents, the practical implications are limited but clear. Individuals diagnosed with measles will be required to isolate until they are no longer infectious, while close contacts may be assessed and advised based on their level of exposure and vaccination status. These measures are intended to minimize disruption by concentrating intervention where it is most effective, instead of relying on general advisories or widespread closures. Vaccination remains the primary defense against measles. Authorities have reiterated that existing immunization requirements continue to apply, particularly for children, and that high coverage levels are essential for maintaining community protection. Adults with uncertain vaccination histories have been encouraged to seek medical advice, although no new vaccination mandates have been announced as part of the current response. At the system level, the situation illustrates how Singapore manages health risks in a densely populated and internationally connected environment. Imported infections and sporadic local transmission are difficult to eliminate entirely, even with strong safeguards. Public health policy therefore prioritizes rapid detection, isolation, and containment, preventing small clusters from developing into wider outbreaks. Health agencies have stated that the situation remains under close review. Case trends, transmission patterns, and the effectiveness of current measures will inform any adjustments. At present, there is no indication that additional restrictions are being considered, and officials have stressed that the existing response is proportionate to the level of risk observed. In summary, the rise in measles cases has prompted firmer but focused action. Mandatory isolation and contact tracing are tools aimed at protecting public health while preserving normal daily life as much as possible. For residents, the key message is continuity rather than alarm. Vigilance, timely vaccination, and cooperation with health authorities remain central to keeping measles contained in Singapore. Singapore has reported a recent increase in measles infections, prompting health authorities to introduce mandatory isolation for confirmed cases and strengthen contact tracing measures. According to official updates, case numbers in early 2026 were higher than in the same period a year earlier, reversing a long period in which measles incidence remained very low. Measles is classified as a notifiable infectious disease under Singapore's public health framework, requiring all confirmed cases to be reported to authorities. It is also recognized as one of the most contagious viral diseases, capable of spreading rapidly in settings where immunity is incomplete. Health agencies have noted that a single infected individual can transmit the virus to many others if protective measures are not in place, particularly in indoor or densely populated environments. Laboratory investigations into recent cases showed that some infections were genetically linked, even though the individuals involved had no known contact with one another. This finding suggests that transmission may have occurred in the community without being immediately detected. While the overall number of cases remains limited, such patterns raise concern because measles can spread before symptoms are obvious. Singapore previously managed measles through advisory isolation and routine surveillance, supported by high vaccination coverage. However, the recent rise in cases led authorities to conclude that stronger enforceable measures were needed to reduce the risk of wider transmission. As a result, isolation orders for confirmed cases are now mandatory rather than voluntary. Vaccination continues to be the cornerstone of measles prevention. Under existing regulations, measles vaccination is compulsory for children, and coverage rates in Singapore remain high. Even so, health officials have cautioned that small gaps in immunity, whether due to delayed vaccination, incomplete schedules, or imported cases, can still allow the virus to spread. The decision to impose mandatory isolation reflects a shift from precautionary guidance to targeted public health control. It is intended to contain infections quickly without resorting to broad restrictions affecting the general population. To understand how these measures apply on the ground, it is important to look at what isolation and contact tracing involve in practice, and how they are implemented once a case is identified. Under the updated public health measures, all confirmed measles cases in Singapore are now subject to mandatory isolation for the period during which they are considered infectious. Health authorities determine the duration based on clinical assessment and established guidelines. Isolation may take place at home or, where necessary, in a healthcare facility, depending on the individual's condition and living circumstances. This approach reflects the way measles spreads. Individuals can be infectious before clear symptoms appear, which makes early separation essential. Without isolation, routine activities such as attending school, going to work, or using public transport can create multiple exposure events in a short time. Mandatory orders are therefore intended to interrupt transmission quickly, rather than relying on voluntary compliance alone. Alongside isolation, contact tracing has been intensified. Once a case is confirmed, health officers identify people who may have been exposed during the infectious period. These contacts can include household members, classmates, colleagues, or others who shared in closed spaces for prolonged periods. Each contact is assessed according to factors such as vaccination status, age, and potential vulnerability. Those who are unvaccinated or partially vaccinated may be advised to take additional precautions. This can include medical evaluation, closer monitoring for symptoms, or temporary activity restrictions. In some cases, post-exposure vaccination may be recommended. Authorities have emphasized that these measures are risk-based and proportionate rather than blanket restrictions applied to large groups.